One big area of importance in clinical research is understanding the value of taking a next generation ALK inhibitor and moving it to the first line setting. Right now we have crizotinib and then we have these next generation drugs approved. So crizotinib is a fantastic drug, patient progresses, then they can get ceritinib or alectinib at progression and do well still. What we're wanting to know is, can you take those great drugs and move them into the first line setting, and can a patient do even better when you add it all up than had they gotten 2 sequences of therapy? Because one of the concerns is, what do you do when someone progresses on the best first line drug you have? You're not going to give them an inferior ALK inhibitor after. I mean, I think people will do that, and ultimately, it will need to be studied. But really, you're looking at chemotherapy until maybe a next generation ALK inhibitor gets approved. That is one of the concerns, is what is the value of taking an effective drug in a second line setting and moving into the first line setting? Are you helping the patient overall? I think we tend to believe that giving the better drug first is the way to do that, but really I think more time will be needed to sort out the true benefits in terms of absolute overall survival. The ALK inhibitors that have been approved include crizotinib, ceritinib, and alectinib, and there's a shift in the line of therapy that those drugs are effective in now, all moving into the first line setting. There are other agents in development. One of them in particular, brigatinib, was recently FDA approved to be used in the second line setting. There are other agents behind that. One is called lorlatinib, an agent that looks to be very effective as well. The pivotal trials of lorlatinib are just getting underway, so comparing how that drug does versus more standard therapy like crizotinib will help define whether that drug can move into the first line setting. And there are at least 2 other agents in development that look promising as well. So when you add it all up, we have 7 ALK inhibitors. 4 of these are already approved, 3 are on the horizon, and probably others in the future. The hope would be that we would have drugs to be used in sequence. So someone's on a great drug, they progress, they get another great drug. And I think more research will have to be performed to understand the sequencing of these drugs. And these trials are in progress to look at that sequencing issue. It's hard to predict the future. For right now, it's been to just design a better drug. So take your best treatment and see if you can tinker with it a little bit and find a way of making it more effective. That's been a good strategy, not just in ALK drug development, but in CML and in the EGFR setting. But it's hard to do. It's hard to ultimately keep doing that. And you may reach a point where you have the best inhibitor on the market, and you may not be able to fine-tune that much more. And so the big question is going to be, can you develop other drugs for alternate escape pathways or resistant pathways? There already have been data in the Mass General group has shown that you can treat somebody with a drug, develop resistance, treat with another drug, develop resistance, and come back to the first drug. So it may be that if you just have a toolbox filled with agents and you really understood what kinds of ALK rearrangements and mutations they were effective against and which ones they don't work against, in theory you could test a patient at progression and decide that you get drug A this time, you get drug B this time, and maybe drug A later. That may be a direction we're headed, where blood-based testing can solve that sequencing. Or it may be that we decide that adding immunotherapy to these agents or some other novel combination makes more sense. The best example I can think of is in BRAF mutated lung cancer, where we know BRAF inhibitors are very effective, but when you add a MEK inhibitor, you can enhance that efficacy and probably improve safety. There might be strategies like that in the future of ALK drug development, but for right now we have multiple agents, single agents that are in development.